Hey everyone, Dr. D here again with Beltline Health, bringing you the latest video to help you have the smoothest possible experience when you come to us for your weight loss surgical needs. Today, we plan to cover the preoperative appointment. Basically, I want this slideshow to act as a review for a typical preoperative visit. In no way is this supposed to be a complete substitute for your preoperative visit. Hopefully you will come to your preoperative visit, and if you're seeing this, maybe you already have. There's no doubt that we won't proceed to surgery without this visit, and realize that specific topics tailored to your needs need to be discussed in person for the safest, smoothest experience. But I try to make some highlights or general things I say available here for your review, since I know that we cover a lot and we tend to move kind of quickly, and so I want to make sure we can get another repetition in for you to watch on your own time. So let's proceed with that. The outline for today, we're going to cover preoperative clearances, preoperative diet, medications, consent, day of surgery expectations, and what it takes to get back home after surgery. Clearances. What are the clearances? Well, it's actually everything that you worked hard to do to get qualified for surgery. So I want to review all those tests, starting with the Frontera testing. We want to review that heart ultrasound you had done to make sure that it's got normal structure and function. The C-MET test, that was when you rode that exercise bike and we checked your lung function. Hopefully we got that report and an okay to proceed with surgery. Usually they'll comment if you're low, intermediate, or high risk. And also ultrasounds. Frontera did some ultrasounds for us from your legs up to your abdomen. In your legs we looked for blood clots. Hopefully you don't have any blood clots and therefore don't need to start any high-dose blood thinners. And also we ultrasounded your liver and your gallbladder. I tend to screen for that because two reasons. We want to get an idea if you have any advanced fatty liver disease or surprise liver masses that we can look at or biopsy at the time of surgery, or maybe we need to put a hold on surgery because you have something that needs to be addressed. One of the other things that can be addressed is gallbladder disease. I may have told you in your original visit that all our weight loss surgery patients carry about an 8% risk of needing a second surgery in the future related to their gallbladder. As a brief reminder, when you're losing weight rapidly, that's when you circulate and concentrate cholesterol. Your body's clearing that cholesterol because you're burning so much weight so quickly. When it can't get all that cholesterol into the nice clear liquid form, the bile, it tends to concentrate and make stones. So there's something like a 30%, 20 to 30% risk of forming some kind of sludge or stones, and then 8% of patients that form that sludge or that stone are going to then go on to have a potential painful episode or some other sequelae of gallstones requiring that gallbladder surgery. So the reason I like to screen beforehand is following a previously done study in the research world. If you have no stones in your gallbladder, or on occasion if I say you have some sludge or some low level of granularity in there, I can offer you a medication. I call it ursodiol, or it's also known as Actigol, sorry, to prevent the formation of worse or new gallstones. And if we can do that potentially with up to 93-95% success, we can prevent the formation of those gallstones, maybe avoid a surgery. So anyway, that's why we got the ultrasound of your gallbladder and your liver. It's at this time that I may be mentioning, hey, you're someone that a few months after surgery we need to plan to take that gallbladder out, especially if it's acting up. Or I may say let's plan to biopsy your liver at the time of surgery to get information whether or not you're at high risk for some other process such as liver cirrhosis. So those are some things that we would address in that regard. Psychological and medical letters, we hopefully obtained those already. You went and saw a psychologist to make sure you understand the gravity of the decision you're making, how much of a life change this is going to be, and are you fit to undergo the operation. We also got medical clearance letters either from our own Dr. McDaniel or one of your primary care doctors. Upper GI study and EGD. Why do we do this? I wanted to screen you for symptomatic or asymptomatic gastroesophageal reflux disease, or GERD for short. Most commonly, all anyone thinks about is heartburn. Do I have heartburn or not? We probably talked about that at the original visit. And or you may have had an EGD, a formal look with a camera down here with some biopsies. Again, the goal here is to see, I think the main goal here is to see if you have any subtle hiatal hernia, especially if you're undergoing a sleeve gastrectomy, which can increase your risk of heartburn or cause new onset heartburn up to 15 to 20% of the time. I want to make sure if there's anything that's actionable, something we can act on and fix, that we do so. So these studies will give us some of that information, and excuse me again, give us the opportunity to talk about adding a procedure at the time of the weight loss surgery. Again, these are the main reasons we do these things. We want to let your insurance know we found a hiatal hernia if it's not too late as well. And then, did we find a bacteria during some of those biopsies done at the time of EGD? Do we need to treat those things? Hopefully that already happened, especially if you went and had your EGD done with one of those great gastroenterologists. And of course, last but not least, the dietitian education. You did a minimum of 3 dietitian classes. You got a bunch of handouts. I'm going to harp on it later, but hopefully you have those with you, if not at your visit, ready to go in your preoperative journal or your My Weight Loss Journey diary or journal, hole punched and in there and ready to go the way I told you at the first visit. And maybe your insurance required 6, 9, or 12 of these visits. Either way, if we're seeing you now for your preoperative visit, you got all that good education. It's time to put it to use. Let's talk about that preoperative diet briefly. I very intentionally put this semi-low quality screenshot of your Beltline Bariatric patient handouts in here, and I only put one slide in here. This is a good time for me to just say, hopefully you have your handout. If you don't, this is a good time to ask for one, or have your dietitian email you a copy, or your medical assistant. So critical. You need to have this. This is so important to have as part of your journey. I want you to have it now. You should already have it, but if you don't have it now, you don't ask about it a day, a week, a month after surgery. You're behind the 8 ball, people. The reason being, some of the key things in here as it relates to your preoperative visit, you should already be on a preoperative diet. Why do we have you on a preoperative diet? Well, we want to kickstart your weight loss, right? But also it has this important function here of shrinking your liver and helping improve your postoperative outcomes. It can very directly help limit the risk of, say, bleeding. I at some point want to update this and put in pictures of a large fatty liver obstructing our view versus a nice shrunk up healthy liver that just makes for easier surgery. This is one of the physical things that you can control that actually makes your surgery go smoother. When you have a large liver and a large fatty liver that's not been at least optimized or begun to shrink down, it can be not only large and like block our view in this tight area in the upper abdomen, but also it can be tends to be less firm. We can't grab it and move it out of the way. When we put in a retractor, I've seen where these livers have actually cracked or kind of like had a tear in it because it's just large and mushy, and it can't support that liver retractor. So a liver sees the majority of your blood flow kind of like every hour circulates through there. It's a very vascular organ, and it's prone to bleeding, and we just want to avoid that risk. So right now you need to be telling yourself, oh, there's a very real reason Dr. D at Beltline Health wants me to do this diet, and it's for my own safety. And also you need to tell yourself, if I'm seeing Dr. D, at this pre-op visit, and I haven't started this diet. We need to talk about that. You know, we actually, it, as anxiety provoking as it can be to like change an operative date, this is something that can make a big difference. I suggest if you haven't started this that we don't do some partial or kind of half effort on this diet. Like, let's move that surgery date and do it right. So this diet should start 2 weeks before surgery, as the slide says. That's going to be days 1 through 12, where you're going to follow this top half of the diet right here, and some suggestions in here about how to go about doing that diet. And then starting days 13 and 14, you're going to transition to a more aggressive diet, where you're going to go basically to clears only. And this is really where that liver starts to get an opportunity to shrink. And then again, a list of items. I always get questions about, well, Dr. D, I did start that diet, but you know, what should I be doing? What are some things I can drink or eat? It's kind of laid out in here. So again, the key is to have this handout by now. Another thing I want to say about once you're transitioning to the true 2 days before surgeries, surgery diet, this is a good time to ask yourself, do I have my preoperative medications ready to go on my shelf? Do I have my vitamins purchased and ready to go? Here it is again, another kind of direct screenshot of the handout, examples of what the pre-op diet meals should look like. I almost always get the question at the pre-op visit, you know, what are some things I can eat? Well, do you have the handout? I don't have it memorized, so you're going to hear me say that. I actually do know some of the elements of the diet, but I want you to know, and I want you to feel comfortable going to this document. And if you're not old school, you don't have it folded up in your purse or your pocket, you know, that's cumbersome. Well, we all come to our visit with a nice smartphone, right? So you should have that email flagged and saved in a special bucket, your Beltline bucket maybe, or folder I should say, and have it saved. Let's talk about medications. Again, this is actually a very important kind of part of the visit, and this specifically is something that should be tailored to you, because you come to your weight loss journey and your preoperative visit with your own list of medical problems and your background. You may be on 1 or 2 diabetes meds, you may be on 1 or 2 hypertension meds, you may be on a cholesterol med, or hey, you may be someone who's on 0 meds already. And I'm going to tell you, hey, you don't have to worry about stopping a medicine before surgery and how many days to stop before surgery. But if you are on some medications, we need to tailor that discussion to your specific needs. Sometimes it's dangerous to stop certain medications too aggressively or too soon before surgery. So this is just so critically important. The other thing is, you know, I'm going to give you what I think are the up-to-date guidelines and how I'm used to structuring people's medication regimen. But these days, we actually work closely with the surgery centers in the hospitals where your surgery is scheduled. And generally, someone from the anesthesiology team is screening everyone as they come for their pre-surgical visit, so that's important. And hopefully, they're telling you which medicines they think are critical to stop. They may have some new knowledge or specific specialty knowledge about which medications interact with their powerful sedative medications and to please stop them, or we're expecting the fluid levels in your body to go up or down during surgery. So that could cause certain kidney risks based on what medications you're taking. Without making this complicated, notice I put it in red. If we did not discuss medications at your visit, okay, if you have not heard from the anesthesiology team at pre-surgical testing at a Northside hospital or a Piedmont hospital, that's really odd, and you should be asking yourself, what should I be doing? And you should insist on getting that information. If it's 2 days before surgery, you're behind the 8 ball. Hopefully I'm seeing you the week before surgery and you're getting a link to this video the week before surgery, so you're asking about this at least a week before surgery so we can tailor your needs. There are some medicines that need a full week to hold. Generally it's blood thinners, but we want to address that. Let's talk about another set of medications. These are the medications that I told you at your visit that I'm going to send to your pharmacy. Also, I've made a note here, or Piedmont Pharmacy. I'm referring to a specific pharmacy within the Piedmont Hospital in Atlanta. Sometimes I will give you the option to have medications sent there, and I think they have a system to deliver medicines for you to your room. So if you're interested in that, hopefully we talked about it and you provided that information so we know where to send your medications. Let's talk about pain. I actually talk about this a lot in the pre-op visit, maybe more than some other surgeons. I think it's important for you to know that there's been a kind of a paradigm shift in how we handle postoperative pain, and I'm going to go into detail on this on the next slide. But here I want to talk about what medications I'm sending to your pharmacy for your postoperative pain coverage. We want you to have a reasonably comfortable surgical experience. So we are using a protocolized and well-researched set of medications to make for a great experience and a low complication risk. These medications I'm going to send include an anti-inflammatory called Celebrex and a nerve suppression medication called gabapentin. This medication acts on the nerve specifically to help suppress those nerve signals. Your nerves tell you that you're in pain at a certain site. I'm going to point to my belly because that's where our surgery is. And then they transmit that through your spine up to your brain. So gabapentin is something that can potentially dampen that transmission of that signal. Then we have Tylenol. You know, I always have patients frequently raise an eyebrow to this. Tylenol really for surgery? Well, you got to realize a couple of things. When I send it to your pharmacy, they may not actually give it to you in a bottle because it's so widely available over the counter. But I usually send it in anyway, so maybe it triggers them to remind you to get it and how to take it. So it's 1 gram, 1,000 milligrams. Usually it's 2 of those 500 milligram tablets at a time every 8 hours around the clock. And when combined with these other 2 medicines, believe it or not, this does a better job suppressing pain than narcotics. So keep that in mind. We also like Tylenol because it's safe. It's been used for years and years. So just because something's over the counter doesn't mean it's not as effective as something else that a doctor had to write for. It doesn't mean because it's not new that it's not the greatest either. Again, I'm not just making this up. We have research studies to back the use of this pain protocol. Then I'm going to send in a medication that's for as needed purposes. This is more for those internal crampy intestinal pains. It's hard for me to describe what that might be like for you, but know that if you're taking these 3, okay, and you're still having some other pain, different quality, kind of crampiness, spasms, that you'll have another medicine that you can take. Next is nausea. If you're experiencing nausea, you know, there's going to be, first of all, a scheduled medicine to prevent nausea. Okay, this is important. I highlight it because highlighted medicines are medicines that you should take before surgery. So in the scheduled arm of the nausea meds that I'm sending to your pharmacy, realize that there's a great drug called Amend. This specifically, we think, acts in that postoperative prevention time frame right after the general anesthesia. When you have this on board, it tends to counteract the nausea side effects of those anesthesia medicines. So when you're in the recovery room, we want to bat down that nausea from the get-go. Why? If you wake up nauseated and you start to retching on your brand new incisions, it can cause problems. Honestly, it can provoke pain that we then have to spend time catching up on because you've really engaged your ab muscles to cough and retch. And then also because on the inside, retching actually increases our pressure all in our chest and our belly. And sometimes, you know, I gotta wonder if we had an early take back to surgery, it was because of a violent kind of episode around the time of waking up. So I'm not guaranteeing anything with these medicines, but Amend is something I want you to take the night before surgery, and I will try to order it the morning of surgery, but hospitals dictate, even if I think something's great for you, they'll say, hey, we don't want to pay for that, and you may not get it. I'm sorry, that's just the honest truth. So we try to send it to your pharmacy beforehand so you can take it the night before at least. And then the anesthesia team there may try to substitute something other than Amend, but I will try to order it for you the morning of surgery too. As needed meds that I'm going to send to your pharmacy, Zofran, or also known as ondansetron, It's a great medicine that we're really carrying over from the chemotherapy cancer world because it's so great at batting down nausea related to that strong chemotherapy that we're using it in our postoperative nausea control um, setting. Blood thinner scheduled. So after surgery, you're going to take a medicine called Xarelto or Eliquis. One or the other. Usually I'll try to send Xarelto first, and if that wasn't approved, I'll send the Eliquis. And I'm not going to list it here, but if that's not accepted, unfortunately, I'm going to try to send an even older version of a blood thinner, but unfortunately it comes in an injection form only, so you may have to give yourself injections. But hopefully not, we can get this to you generally approved, and if not, these companies offer great coupons, so you can sometimes get it for free for a small supply. Um, the reason for this is if you're seeing us for an unhealthy weight and you're undergoing a major abdominal surgery, you're going to have a relative period of rest where you're not as mobile. But the bottom line is surgery can provoke blood clots, and if you're overweight, by virtue of being overweight, you're at higher risk for blood clots in general, whether or not you knew that. So your best friend for preventing this is walking. Honestly, most surgeons out there are so worried about a bleeding risk, even though there's a lot of data now that says there's no increased bleeding risk from these meds. And so we believe we should optimize and prevent blood clots because we can handle little bleeding. It's scary, but it's not likely to kill you. But what can kill you is a blood clot in your leg that traveled up to your lungs. I'm sorry, it's scary to talk about and think about, but then again, that's why we want to optimize your chances of not having that happen. I dislike hearing after surgery that, Dr. D, I took that blood thinner for a few days and then I just decided to stop. Or when I took it, I thought I had a little symptom somewhere, a little side, I couldn't tell if it was side effects, so I just stopped. Well, come on, people, if you're stopping a medicine that I think could dramatically improve your risk of a major complication, well then call me and talk to me. Don't just stop it on your own and think that you have 4 years of pharmacy PhD training or a decade of training like I have doing surgery and using these medicines and things like that. So let's just talk about it. This is definitely one I want you to take as it says on the bottle. Same with all these other things. Oh, I forgot to mention, I can't tell you how many times I get a call after surgery and someone's having pain, and the first thing I ask them is, did you get the medicines I sent? Did you take them like the bottle said? Oh, no, Dr. D, I was waiting for pain, and when it would wake me up overnight, I would take that Celebrex or I would take a Tylenol. These meds are scheduled around the clock the way the bottle says. That's the best way to use it. So use these things as they say in the bottle. Just read the bottle and take it the way you should to optimize how well they work for you. Then there's an antacid medicine. This is also scheduled, and I gave it a highlight because I would ideally like you to get this early before surgery and take it before. My thought is suppress the acid in your stomach leading up to surgery, get a head start on that, and then of course take it afterwards. If you don't happen to get your medicines till right before surgery and they're waiting at home, it's not a big deal. I've seen surgeons do it both ways. My ideal setup is you at least start a week before surgery with this and just suppressing any gastritis inflammation in that stomach so that when I go cut on it, my thought is if there's no gastritis, maybe there's a subtle role there to optimize healing. I don't want you to get kind of stuck on that. There's not been, to my knowledge, any study that definitely proved that it helped. But I want to optimize things as best as I can. I think that's one way to do it. So here's your comprehensive list. 8 medicines I should send to your pharmacy. Please don't call the morning of surgery, the day after surgery, and say, hey, I never got them. There's no need for that. Ideally, just so you know how it works, we had your pre-op visit, ideally several days before. By the end of that visit, hopefully I sent them. Sometimes if things are going a little slow, I'll just do it right in the room with you so you can see it and we addressed what your favorite pharmacy was. Or our MAs, medical assistants, have a protocol to do it on the Friday before surgery. So sometime by the end of that week before surgery, these should be sent into you. And you should be wondering, I mean, come on, be proactive about your surgery and let's kick this off on the right foot. So don't come to the day of surgery upset like, oh, Dr. D, those meds aren't there. What's going on? Like, you should be wondering days before, why don't I have them in my hand and on my dresser? So that's the best way to go about this. Give us time and be patient with us to get them to you. But we can't help you if you don't know, and if we don't know that you don't have them, and there's no point in calling upset last minute when you could have given us some more time to address this. So again, highlighted meds are the ones to start before. Everything else can be on your dresser, ready to go for after. Probably the most important one to take before that actually, the best way to take it and get the optimum results is the amend. And if you can't get it because your insurance didn't approve it or the hospital didn't give it, they should be giving you something else, like, for example, an anti-nausea patch behind the ear. It's not as good, but it does do pretty good. So, again, have these at home ready to go. Pain, I told you I was going to do a slide just dedicated to pain. So first thing I want to do is just set expectation. Surgery is going to hurt. As someone famously told me, me and you are going to a knife fight on the day of surgery, but you have the disadvantage of being tied up, sedated, and unarmed. So I have a knife and you don't, basically. You're going to lose. If you were awake, you'd never let me come at you with a scalpel, right? So don't wake up thinking like, golly, these days, like, we have a surgery that's totally pain-free. That's just not true. Our goal here is to make the whole experience manageable. Return to function as soon as possible. Truly speaking, laparoscopic surgery, robotic surgery, small incisions, and certain anesthesia protocols are what are making surgeries so much better tolerated these days and getting people back on their feet so quickly. There's an old perception, I think a generational kind of expectation that if you have surgery, you're going to get your prescription of Percocet or Lortab and you're going to wait for pain, and that's just the expectation. I need narcotics. Things have changed, people, especially in the last 10 years with these minimally invasive surgery techniques and, again, anesthesia protocols and a variety of medicines that are available. It's just not the case. And while thousands of people are dying every month or every year in this country from narcotics, we have to get away from it. And we're not just doing it willy-nilly, and we're not setting you up for torture. That's not the plan. There's actually been some data-driven driven protocols that we utilize to help your pain, make it reasonable, and make it safer. Non-narcotic pain control regimens. Why do I harp on this? Narcotics have their own set of side effects that can hurt you, cause complications, and actually hinder your road to recovery. What are those side effects? Constipation is the number one side effect of narcotics. There's already, from the general anesthesia meds, us manipulating and messing with your intestines. They're not going to want to act right. They're going to be slow. They're not going to push air and food down to the bottom as quickly as they used to. Not uncommon after surgery, even if you manage to have no narcotic use, to have 3 or 4 day gap between surgery and your first bowel movement. My patients with narcotics routinely go 7 or 10 days. So if you want 10 days of constipation, I'm happy to write narcotics for you. And I'm not saying I won't. I'm going to cover, how and when we will give you something stronger. But I definitely want you to try to avoid constipation if possible. The other thing that happens with constipation is what I call a nasty pain constipation loop that patients get trapped in. What that means is you're constipated, you're sitting on the toilet, you're bearing down. When you bear down, you're using your core. And guess what? You're aggravating and inflaming your incisions and your muscles where those instruments went through, where I made cuts. And guess what? You have more pain. So guess what? You take more narcotics, you have more constipation. So the loop goes on and on, around and around. The other thing that can happen with narcotics is nausea. You may already have a subtle nausea from having your stomach been cut on. And again, anesthesia meds. Adding narcotics could add nausea to that. Guys, your number one issue after surgery is going to be staying hydrated. It's going to hurt to take a little baby sip of fluid. Number one reason people come back to the hospital is dehydration. So why take something that may make you nauseated and may further hinder your ability to stay hydrated? So I don't want to give you something that may make you feel bad. And of course, drowsiness. So drowsiness has actually killed people after surgery. Sometime, very rarely, patients, generally very sick, very super high BMI, in the past used to go home with undiagnosed sleep apnea. This is why we test for that before surgery nowadays, by the way. would have undiagnosed or undertreated sleep apnea, or have sleep apnea, refuse to use their machine, and then would get sent home day 1 or 2 after surgery on strong narcotics. Narcotics make you drowsy. They actually slow your breathing down. So if you're obese, overweight, you have untreated, undiagnosed sleep apnea, and you're taking a drowsiness provoking medicine, a strong narcotic, you may just stop breathing in your sleep. And sadly, from training to now, I've had this been part of at least 2 cases where that happened, and we think ultimately it was some combination of narcotics and sleep apnea that probably caused someone to pass away the day after surgery. So very scary stuff, heartbreaking stuff. It's avoidable, if at all avoidable. We want to avoid things that make you sleepy, make you breathe slower. All right, so research-driven pain control. Again, to simplify this, old school thought was give someone a strong pain medicine. Tell them to wait till they're having pain. Every 4 to 6 hours, pop a tablet. Well, you may get busy or you may fall asleep because you're drowsy, and then you'll wake up in pain 8 hours later because you'll be behind. So a much smarter way to do this has been determined, and is to take medicines that attack pain at 3 different kind of modalities and take them around the clock so you're not behind. So our regimen, again, involved that Celebrex, Tylenol, and gabapentin taken around the clock for 3 days straight. That protocol in the research study, when taken properly, patients surveyed in that study reported that they had an average pain level that was 6 out of 10 in their subjective scale or less. So that I want you to remember that, like when you're asking yourself about post-op pain, somewhere in that 3 to 6 or 7 out of 10 pain, where it hurts. It's like having a headache, but hey, you're getting around. You're taking care of work, taking care of your kids, making meals. That's where we want you to be. Some level of mild soreness that's manageable. You can still do what you need to do. It's not hindering you from walking and doing things that can also positively affect your recovery. And it's not distracting you in a way that, what I don't want is, oh my God, 8, 9, 10 out of 10 pain, that's so bad that you're just sitting around and for example, if you're not moving and increasing your risk of blood clots, well then we want to treat you with something stronger. So here's that pain regimen. Oh, and I didn't mention it because I was waiting for this bullet. Exparel, y'all don't know what that is. I don't prescribe it, but at the time of surgery, believe it or not, we're going to use a local anesthetic. What is a local anesthetic? If you're like most people and you've had some dental work, that shot you get in your gums that makes you to where you can't feel the drills and everything else the dentist is doing, that medicine is formulated now in a new form called Exparel, where we can inject it in the muscles on both sides of your abdominal wall, in the area where the nerves live, and basically suppress those nerves for up to 2 or 3 days after surgery. I mean, the label says 3 days that it lasts, but I've found about a day and a half or 2 is what you can expect. And at that point, you have a nice loading dose, or you have these 3 medicines on board, the Celebrex, gabapentin, and Tylenol. As that's wearing off, these are already acting on that nerve that's waking up, and that's how we manage the pain after surgery. So that's the key to this, is a pain regimen. And guys, if you ask me what I want, I'd rather have 1, 2, 3, 4 medicines on board acting on the nerve by different mechanisms than one narcotic that's too strong and can give me bad, dangerous side effects. So anyway, this is kind of how I want you to think about pain after surgery. Hopefully, if you're like most patients, by the way, I didn't say it, but the research that drove this protocol, they also reported the number of patients that reported this average pain level was greater than 95%. I believe 93 or 95%. So the majority of people had this experience. So if you're, hopefully you're in that kind of that group, and if you find that this worked, but I just needed a couple days of extra coverage, just know that I am sending these medicines with a refill. So you can go get a refill. I'm okay with you using it for 6 days. The other thing you can do is, if it worked for 3 days and you're actually done, like you feel like you're not having pain, but you get a little breakthrough pain, like day 5 or 6, you go to do something reflexive and you twist your core and you get a reminder pain like, hey, I had surgery, then you can use the Tylenol. Hopefully at that point you've transitioned to Tylenol as needed, or if you have a Celebrex left over, you could take it kind of as needed. So after 3 days, you're going to go to an as needed basis, or you're going to refill these meds. Next thing you can do is, everything was good, but I just need a little more coverage. There's some things you can go to your local pharmacy or Walmart and get that can also help. There's also things you can do at home. Realize that when you woke up from surgery, Dr. D insists on you having an abdominal binder. So that's something that you're going to have on your belly that kind of hugs your incisions, supports them, especially when you're active. So that should be helping control pain. You can do heating packs, heating pad or cold packs to your abdomen. These things act by distracting those nerves from the pain receptors, and can do the job sometimes. It can also relax the muscles, which are in there where the incisions are and being aggravated. The other things you can do is plain gas X. Sometimes these pain medicines are acting the way they should, but you're having, again, in your abdomen, like crampy gas pains, bloating, try gas X. And last but not least, this is a pain patch that I've found has made a world of difference for some patients that called me. Typical situation is if you had a sleeve, where we pull the stomach out, right side of your belly button, usually for all three of us surgeons at Beltline, that will start acting up when that expiral numbing medicine has worn off. So day 3 or so, you're starting to be more aware of your incisions. Pick the incision that hurts the most and put one of those pain patches on there. And for any over-the-counter medicine and my prescribed medicines, take it the way the box says, okay? Now, you've done all that stuff. You're trying to do the right thing for yourself. You're still having a persistent 8 to 10 out of 10 pain. You're asking yourself, hey, what's my pain with all this stuff going on? It's still consistently 8 to 10 out of 10 with or without other concerning symptoms. Am I having a fever? Am I having nausea, vomiting? I'm not tolerating liquids. That's kind of weird. You know, that's weird. Remember, 90+% of patients never needed to call me. This regimen worked. So if that's you, the reason I go about all this trouble is I want this to trigger a phone call. I want you to call me, try to talk to me and explain what's going on. This is a trigger for us to say, hey, do we need to wonder, you know, is something else going on that we need to test and assess for? And if that's not the case, we talk through it. I feel like you're still safe. You can stay at home, continue your recovery. Then I can send in something stronger. So at that point, you've called us, we've talked. Hey, you need a Lortab, you need a Percocet, I'll make it happen. It's really simple. This was a long-winded discussion. We're not going to make it that hard. If you call and we feel like you're safe, you just need some extra coverage, or you're a patient that already has a prior exposure to pain medicine and we know you have a tolerance or something, this regimen may not work for you, so we're going to send something stronger in, okay? We don't want you to suffer. I want to have a career where I didn't have someone go home and have a really bad outcome that maybe we could have avoided, okay? Let's talk about consent. The next big category. Again, this is something that we should talk about that's unique to you. First of all, what am I writing on your consent? Are you having a sleeve, a bypass, a switch, or a revision? Are we combining that with a gallbladder surgery, a liver biopsy, a hernia repair, something else? So again, I said it in the beginning, the disclaimer, this isn't a catch-all kind of presentation. We very much should have covered this at your preoperative visit, but I just want to generally tell you some things about a consent. First of all, the main consent, the actual form you sign, we do that at the hospital on the day of surgery. So what we're going to do at the preoperative visit is hopefully talk about some details about what the risks are of surgery unique to you, and then have an opportunity for you to ask me questions and express your concerns. Hey, I read this online, I heard this, my cousin had the surgery, they experienced this. This is the time that we're going to talk about all that. We physically sign the form at the day of surgery. That means you have another few days to think about things, talk to people, and again, at the day of surgery, you'll see me and have another opportunity to ask questions. The broad categories I cover, I include these at least because they overlap with all of those consent discussions and the different surgeries. I'm going to talk to you about pain, acute pain from surgery, just like that last slide. You're going to hurt after surgery. I'm going to tell you that, emphasize that. And then you may have chronic pain. Once in a while, we just can't help it. We do a perfect surgery, but your nerves, due to genetic factors or bad luck, it gets trapped in little scar tissue, and it could be aggravated and give you reminder pains for a prolonged duration, like weeks or months after surgery. Can't do anything about it. It can happen up to 1% or less of all the cases. So bad luck, chronic pain, and then I would probably talk about bleeding. There's a risk of bleeding, and will you require a blood transfusion? And then I'll ask you if you have any religious reasons you can't get donated blood. We want to be aware of that. Pain, bleeding, infection. You can get infection in your incisions. You can also get infection in your belly. Usually I highlight the fact that we worry about leaks predominantly after surgery. Again, it's about a 0.5 to 0.5% risk for most people that something doesn't heal right, your stomach or intestine, and it leaks. And we have ways of catching that and treating that. Then I talk about injury to surrounding structures in your belly. So we're there to work on your stomach and your intestine, but it's always possible. I'm a human. All the surgeons are human. We may have an inadvertent injury. I'm never going to leave the OR with, hey, I just injured you, and hey, I left the OR with you having an injury. That doesn't make sense or happen. That's why we're trained, and us general surgeons, we're trained on the whole body. So if we have an injury, we see it, we're going to try to fix it, or in surgery, I may go call an expert to come help me out. So we're not going to leave the surgery with a known injury. Sometimes injuries happen and they don't manifest till days, weeks later. So just keep that in mind. But generally speaking, knock on wood, I've never had just a straight up inadvertent injury that caused direct harm up to date. And then if I did, I'm going to take good care of you and make sure we get the help you need to solve that problem. And then last but not least, things that are out of my control, unexpected results. Maybe you don't lose as much weight as you were hoping. Hopefully I had that realistic talk with you about expectations. The weight losses that I would have quoted you were all estimates. I don't guarantee any certain weight, but hopefully we picked the right surgery based on your goals and what you had in mind, or you may have been willing to be a little above your goal weight because you just wanted a certain surgery for simplicity or safety. So I can't guarantee weight results. Sometimes surgeries go great. Your genetics are so strong that it's going to hang on to weight more than the average population, right? I can't control how much loose skin or how much hair you're going to lose, or how much loose skin you're going to have, or how much hair you're going to lose. I can't control scars. Some people make scars that look more prominent than others. I can't do anything about that. I'm going to do my part to make small incisions and do neat, nice little closures. We got to pray we don't have infections that can lead to worse scar, and maybe genetics I can't control that causes bad scar. Other issues like malnutrition. Hopefully you have your vitamins. This is why we harp on it. All these surgeries can actually cause problems if you get low on critical vitamins, so I repeat that now. And last but not least, sometimes we do everything right, and if the patient's you're doing everything the way you're supposed to in terms of your diet, it's unfortunate, but less than 1%, about 1% of patients will report a chronic nausea. I just have nausea all the time now since my bypass. I have diarrhea with every meal. Well, is it dumping syndrome? Are you really being honest with yourself about how you're eating? Well, sometimes if you are, and it's happening, it's just, again, your genetics, how your intestines are formed and made, and how they react to surgery. Unfortunately, of course, we'll do tests and figure out if something's not right down the road, but sometimes people are just stuck with some chronic symptoms that it's bad luck. The day of surgery, please arrive early. We can't do surgery anywhere other than in the hospital. You may be told my surgery's at 3 p.m., so I'm going to try to show up right at 1. I don't want to be there a minute too early. I don't think that's a good attitude to have. I've had so many patients get caught in traffic, this, that, or the other, and it delays the whole day. It gives your other Beltline bariatric cousin, if you will, who's having surgery on the same day, less of an opportunity to start on time and to get discharged on time. If you show up late, your surgery starts late, you leave later. I get it. I mean, I don't want to be in the hospital. I want to be in and out of there too. But in an age where we have so much entertainment on our phones and we have access to this or that, don't be afraid to come there and spend your free time there. It's just a day. And who knows, maybe we're ahead of schedule. We did the surgery before you a little faster than we thought, and you get a chance to go early and again leave early. So Again, surgery can't be done at home. It can only be done at the hospital. So get there with plenty of time to kind of react to changes that may be happening. Here's another situation. We decide morning of, like, something's not right. You don't feel well. We need to check labs. Well, I can't tell you how many times I was ready to go back and do a surgery and start, but the anesthesiologist ordered some labs, and it takes time for them to come. You're a tough stick. It's hard to find your vein. Before you know it, an hour's gone by and we don't even have that blood yet. So just show up early so we can tailor your experience to you and still have time to do things effectively and efficiently. You will see me one more time and have a chance to ask questions. Remember, we signed that consent. You're not just going to roll back to surgery without seeing Dr. D, and I'll get a chance to ask you who you brought with you, who's your loved one in the waiting room, and again, cover what to expect after surgery. After surgery, I'm going to meet your family and tell them how it went and what I saw. And then I'm going to put in admission orders. Generally, all our patients stay one night after surgery to take advantage of having a nurse, a trained nurse, there to address your needs. We want to do a few things to make sure you're ready to go home and make sure you're safe. What are the things that we need to do? I talk about Dr. D's Rule 5. 5 boxes we want to check to go home safely. Number 1, are you stable on your feet walking? Number 2, are you hydrating at goal? Are you taking about, I'll go ahead and tell you the guide now, a small children's medicine cup, about 10 to 15 milliliters of water or some clear liquid every 15 to 20 minutes. If it's not going pretty easy, you may need to use your phone and set a timer and a reminder. And every time while you're awake, that timer goes off, I want you to drink. Again, if you can't maintain your hydration by mouth, once you're at home without your IV, in a summer, especially in the summer, that there is the reason why the majority of our readmissions after surgery have to do with dehydration in the summer months. So we want to make sure you're hydrating at goal, and then we want to make sure your pain is reasonably controlled. Again, about a 2 or 3 to 6 out of 10 pain on the pain regimen. By the way, I start the same pain regimen I sent to your pharmacy is what I put you on after surgery. I do make available for the nurse to give you a couple of stronger things that you won't have at home, but try not to use them if you can do without it. Please don't have the mentality of I'm just gonna sit in bed and try to experience zero pain and take advantage of the good feeling that some pain medicine gives me. That's not a great attitude. It's unsafe, and you won't have it at home. So you want to try to start treating yourself like you would at home. This is a good time for me to say this. When I was in Texas before I came here to Atlanta and joined Beltline, we had a protocol where generally healthier, lower BMI, especially sleeves, but also some bypass patients went home the same day. So I would say the majority of my patients in Texas went home the same day. So there again, we're shifting paradigm. It's no longer a surgery, oh my gosh event where you need to expect to have bed rest afterwards. Get back to your normal function as quick as you can. These protocols I'm talking about, they're not made up. I'm not doing them to torture you. We want to get you safely back to normal as fast as possible. Treat yourself, although you're in the hospital and have the advantage of someone checking on you, maybe giving you a hand for this or that, start treating yourself like you would be at home. It just makes for a better recovery. The next box you want to check is make sure you have stable heart rate, blood pressure, oxygen, and then appropriate labs. I do check at least your blood level the next morning. Sometimes I check a full set panel of labs, and we want to make sure there's no surprises. When we check these 5 boxes, guess what? It's time for you to go home. I'll put in those orders as soon as I can, and you'll hopefully be home around noon the day after surgery. Another thing I want to say is generally I or one of my partners, Dr. Proctor, Dr. Eduardo, or someone was going to come and see you. If we can't make it because we've started clinic the next day or dealt with an emergency overnight, I'll try to get our PA to come and see you, especially at Piedmont. Someone will come and hopefully check on you and answer your questions. But y'all, again, in an age when the majority of my patients used to go home the same day, realize that also in a modern era, I can check these labs and vitals on the phone. I can chat with your nurse pretty much in real time these days. So probably I'm going to talk to them, get a report, review the things I need to in the computer, and I may be able to let you go without really you being seen. So that wouldn't be abnormal. Don't be offended if we're all tied up and we can't get to you. we're still going to make sure you're safe and take advantage of the facilities we have at the hospital. So that concludes the preoperative review, and hopefully you found this helpful, and you have a place to come and re-listen to it leading up to surgery. Share it with your loved ones so they're on the same page. And as always, stay tuned for the next video that I plan to put here on my YouTube channel. And that'll have to do, I plan to put a video soon about postoperative expectations and kind of your postoperative recovery guide instructions. And so stay tuned.